Everyone. Today I'll be speaking about delayed growth of a child and then what needs to be done. So let's first discuss what are the determinants of postnatal growth. So the postnatal growth is determined by the hormones, genetic potential of a child, and the various factors which helps in growth regulations like vitamin D. So if we see for the infancy, the major factor which regulates the growth in infancy is the nutritional status of a kid. Later, as the child grows, the prepubertal children, their growth is influenced by the hormonal factors like growth hormone IGF-1 axis, insulin, and the thyroid hormone. Then, most important is the hereditary. The later, when there is a post-pubertal spurt, the gonadal steroid hormones plays a very important role in increasing the height of the kid. So before coming on to the short stature, we have to see what is the normal growth pattern of a child during the childhood. So here we can see the two graphs. The above one is the height in centimeter and the below one is the height velocity. That is the height gained centimeter per year by the children. So when the child is born, the height is generally around 50 centimeter in height, the growth with 50 centimeter. And then during the initial first year of the life, they grow by 25 centimeter, and by second year by 12 centimeter, and by third year of life they grow by 8 centimeter. And then there is a slowing of growth by 5 centimeter per year, and then we have the post-pubertal growth spurt, which is for the boys it is 9.5 centimeter per year, and for girls it is 8.3 centimeter, which accumulates to be around, the boys gains height around about 28 centimeter during their puberty time, and girls gain by 25 centimeter. So now what is the patients who need to be evaluated for short stature, or how do we define the short stature? So first, it's very important that we measure the height correctly. So the child has to be without footwear, heels and back should be touching the wall, they should be looking straight, and firm pressure should be applied to the mastoids from underneath. So here we can see the growth chart. So the growth charts plays a very important role in determining whether the child is a short stature or not. So any child whose height is below the third centile or 2 standard deviation for age gender in a given population, that we call term as short stature. Or when the height is more than 1.5 standard deviation below the mid-parental height, or when there is a fall in the growth velocity below the 25th centile, that we call the child is having short stature. So how do we calculate the standard deviation? The standard deviation we calculate by subtracting the height at the 50th centile from the third centile and then divide by the 2. That is called the standard deviation. When it is 2 standard deviations below for that age, that is called the patient is having short stature. Then the height velocity, we do not measure the child's height every 1 month, every monthly. We measure them over the 6 months, over the 1 year. If in spite of that the patient is not gaining the height, or the patient's height velocity is not increasing, then also we term that the patient is having short stature. So these are the tools for monitoring the growth charts. So for the patients of age less than 5 years, we use the WHO growth charts, and when the child is more than 5 years, we use the IAP growth charts. So both the charts for boys and girls are different. Then we have the syndromic charts also for the Turner syndrome, achondroplasia, and Down syndrome. They are different. So very important is to calculate the mid-parental height. So why do we want the mid-parental height? Because it helps in predicting the height of a child according to the genetic potential. So the MPH is for the boys, we calculate by measure the father's height and mother's height, add it, divide by 2. For the boys, add 6.5, and for the girls, subtract the 6.5. That is the mid-parental height for the kid. And then it is very important that we calculate the height age also. because height age again tells us about the what is the genetic potential of the child, and at what point the child was having the disease also. So that we calculate by the height age. So height age is the age of the child at the 50th centile. The growth velocity or the height velocity is the child's height over the period of time. We generally see over the duration of 1 year. So these are the another important for calculating, for predicting the height is the bone age. Then we determine by the atlases which are available online also. We generally use a Grulich pile atlas method, or we use the Tanner Whitehouse method. All the softwares, they are available online. So the bone age also helps in calculating whether what is the genetic potential of the child, or what are the other, like we can sometimes diagnose with the photograph of the wrist joint, like the patients are having rickets or the patients are having Turner stigmata, we can see from the hands x-ray also. After seeing for the bone age, after calculating the bone age, then we have to see whether the child growth, it is proportionate short stature or disproportionate. So generally by 8 to 10 years of age, the upper segment and lower segment ratio is around 0.8 to 1. So if the patient is having the upper segment to lower segment ratio is more than 1, and the patient is having the short limbs, then the differential diagnosis is either the patient can have hypothyroidism, rickets, achondroplasia, or osteogenesis imperfecta. If the upper segment to lower segment ratio is less than 1 and they are having short trunk, then the differential diagnosis is mucopolysaccharidosis and kyphoscoliosis or any kind of skeletal dysplasias. So first we see whether the patient is having short stature by calculating from the bone age, or by seeing for the height velocity and calculating the standard deviation, or the patient is having they are having less than third centile. So when we have diagnosed the patient is having short stature, look for the dysmorphic features. If the dysmorphic features are present, then they are a separate entity, like either they can be Turner, Down, or Russell-Silver syndrome. If these dysmorphic features they are absent, then we have to look for whether it is disproportionate short stature or proportionate short stature. So disproportionate we have already discussed. In proportionate short stature, then we check for the height age, weight age also. So whether the weight is more or not. Generally in endocrine disorders, the patients, they have more or they are overweight as compared to their height. So if the height age is more, if the weight age is more, then either they can be growth hormone deficiency or the Cushing syndrome. If they have normal weight for height, then we have the normal variants of the short stature, that is CDGP, that is constitutional delay in growth and development, or FSS, that is familial short stature. Or if the weight is below as compared to the height, then generally the patients are having the chronic systemic illness or malnutrition. So now the short stature, either it can be normal variant. If the bone age is less than chronicle age, check for the weight age. If the weight age is more than height age, mostly it is endocrine problem. If the weight age is if weight age is less than height age, it is more of a systemic illness. So now we will discussing some few examples for short stature. So we have a 8-year-old female. She was having short stature from past 2 years. No history of any systemic or chronic illness. Her height is 110 centimeter with a height age of 5.5 years. And her bone age was, X-ray was done, and the bone age was found to be 8 years. For her biochemical parameters, all the tests like CBC, RFT, LFTs, thyroid profile, they were all normal. So now we have a healthy child. She is having normal appearance, but the height centile is same as the MPH centile. But what we mean by that is the height age of the height is which is less than third centile, and the parental height is also between 5th to 10th centile. So the child is going to grow at the same level, but ultimately she will be the short stature, but the height will be same as that of the parents, because the bone age is equivalent to chronological age. So when the bone age is equivalent to chronological age, mostly the patient is having the familial short stature, which is a normal variant, because the parents are having short stature. So the mid-parental height is between around about third centile. So ultimately the child is going to have a growth velocity about the curve of the third centile only. The next case, again of normal variant, that is the 14-year-old male complaining of short stature since 10 years of age, and main complaint is delayed development of secondary sexual characters. And when the history was taken, the father also had the delayed development of secondary sexual characters. So on examination, upper segment and lower segment was 0.9, that is proportionate short stature. SMR was, pubic hair staging was 1, testicular volume, which we was 4 ml, and the stress penile length was 5 centimeter. So here we can see over the growth chart that the height, because the height of the child was, it was below the third centile, so the child was having short stature, but the mid-parental height, the height age was 11 years. So the patient was having the bone age was equivalent to height age. So there was a family history of delayed puberty. So we diagnosed to have the constitutional delay in growth and puberty. So these are the both where we can compare the growth charts of both the familial short stature and CDGP. So here we can see that during infancy time, both the children, they grow at the similar height, but as they grow, their height velocity slows down, and their height potential is generally less than third centile. But with the familial short stature, at the time of the puberty starts at the normal time and they reach up to their mid-parental height. But that is not for the CDGP. So there is a delay in puberty. So the child, when there is a delay in growth, there is delay in the puberty. So when the pubertal spurt occurs, the patient will have ultimately the normal height as compared to the parents. Now coming on to the next case, so 15-year-old male with a short stature, with is having the deformity, that's the rickets case. So again here we can see the patient is having short stature. The weightage is again low, whereas the bone age again was 7 years and the height age was also low. So the patient, the bone age was less than chronological age, and again the patient was underweight for the height. So we got the biochemical test done, in which the calcium phosphorus levels were low, alkaline phosphatase was high, the PTH was level 64.5, and the vitamin D was also low, which again suggests the patient was having secondary hyperparathyroidism. But as we got it done, so because the potassium was 2.9, the pH, on the ABG pH was 7.1, that means there was an acidosis, and the bicarb was also low. So we made the diagnosis of renal tubular acidosis. So now the next question comes, why there is a growth failure in renal tubular acidosis? Because it is a chronic metabolic acidosis state, so there is an alternation in the growth hormone and IGF axis. Because of the decrease, then there is a decreased 1-alpha hydroxylase activity, which has a detrimental effect on epiphyseal growth rate. So the treatment is generally done with the oral alkali. Either we can give as a bicarb or citrate, which is, if the patient is having proximal RTA, and then in that scenario, so we give the dose about 10 to 20 millimoles per kg in divided doses, and for distal RTA it is 1 to 2 millimole per kg daily dose. So the next case is 8-year-old male with short stature and was having diarrhea and easy fatigability. So the patient's bone age was 3 years. The bone age was below the chronological age, and the weightage was again low. So patient was underweight for the weight. We got all the profile done. His hemoglobin was low, and because the patient was having diarrhea, so we got the tissue IgA TTG done, in which it was positive. So celiac disease was diagnosed to have as a cause of short stature for this patient. Then there is another case in which short stature, patient presented, he was a 15-year-old male with a short stature since 15 years. Again, the biochemical profile shows that the patient was having CKD, which was the main cause for the short stature in this case. So the growth failure in children with CKD is basically because of the poor intake, malnutrition, metabolic acidosis, and because of the alteration in growth hormone IGF axis, and there is a growth hormone resistance at the hepatocyte and the growth plate. So majorly we require the optimal nutrition, correction of acidotic part, anemia, and neonormalization of calcium and phosphate levels. If it's still the patient is not gaining the height, then we can use the growth hormone at the higher dosage. So now the next case is the 9-year-old females, which was again presenting for the short stature. Her TSH was found to be more than 100. So the primary juvenile hypothyroidism was diagnosed. As the patient, here we can clearly see the patient was having, the weight was more. So the patient's weightage was more as compared to the height of the patient. So when the weight is more as compared to the height, then we narrow down the diagnosis. The patient might be having endocrine diseases like hypothyroidism, Cushing, or growth hormone deficiency. So the TSH, when the TFT was done, the TSH was found to be more than 100, and the patient was diagnosed to have juvenile hypothyroidism. So the next case is a 7-year-old male. Again, here we can see the weight was more, the height was less than third centile, and so again, it was an endocrine disorder which the patient was having. So the patient's growth hormone was done, and it was again found with the provocation test also the growth hormone deficiency was diagnosed. So the next case again, which is very common in short stature in the females. So we have to, any short stature female, we do have to rule out the Turner syndrome. For all short stature females, when they are less than third centile, we need to rule out the Turner syndrome. So karyotyping should be done for such patients. And again, in this scenario, the FSH was more, karyotyping was done, and the patient was found to have Turner syndrome. So to summarize, so first diagnose the patient is having short stature. So we need to exclude the systemic causes, any social causes or SGA. And then we have to see whether dysmorphism is present or not. And if the patient is having dysmorphism, then check for whether the patient is having short limbs or short trunk. And then if the no dysmorphic features are there, then weightage has to be calculated. If the weightage is more affected, then generally it is malnutrition and chronic diseases. If the height is below the 2-3 standard deviation, or the bone age is more than 2 years of the chronological age, it is generally to have the endocrine diseases. If the patient's height is between 2 to 3rd centile and the bone age is within the chronological age, generally it is the familial or the CTGP. So the line of investigations, we have to get all the routine investigations for such patients. That is the CBC, ESR, RFT, LFT, ABG has to be done, calcium, phosphorus, alkaline phosphatase, IPTH levels has to be done. Then we have to screen for thyroid function tests, celiac disease has to be ruled out in our area. And if in spite of all this, we are not able to see for the patient for the, we cannot diagnose for the short stature, then the growth hormone IGF-1 levels should be done. If the patient is having malnutrition, then we can do the IGF BP3 levels, and the karyotyping has to be done in all the girls with unexplained short stature. So take home message, in any short child, we have to calculate C for the height and weight, check for the height velocity, height of the parents to calculate the target height, calculate the mid-parental height, height, age, dysmorphic features, check for the systemic examination, and pubertal development staging should be done. Bone age has to be calculated, and appropriate investigations should be done. Thank you so much.
Thank you, Dr. Shweta. Your flow chart is very, very informative.
Thank you, sir.
That gives a ready reckoner how should we proceed.
Thank you, sir.
So I would like you to comment on two things. The daily encounter in OPD, the chappals with pimples, that will increase height. People ask, generally we refer them to you, but for the reference of the audience. And second is, what is the effect of hanging on height? Because these two factors are really important, and parents are very, very, sensitive and curious and do these things very regularly for their children.
See, so you also know they are not going to help, but definitely we should advise our kids that they should do exercise properly. They should do, their workout should be there, exercise should be there, so that the bones, they are strong. But they do not help in increasing the height. It is basically the genetic potential of the patients that that is going to help their increasing in height. But definitely, if the short stature is there, we should not neglect them, because most of the time the parents are very concerned about the height of the kid. They want that nobody should have a short stature. So, but we have to guide them properly that that is not the indication for the growth hormone for every children, because some of the kids, they have familial short stature, and some of them, they have the CTGP. So all the kids with short stature, they are not the candidates for growth hormone. Thank you.